The House Health Policy Committee will come to order. Would clerk please take attendance?
Chair Rogers.
Here.
Representatives Whitsett.
Here.
Carter.
Here.
Hadsma.
Here.
Neely.
Here.
Glanville.
Here.
Kofia. Conlon.
Here.
Farhat.
Here.
Fitzgerald.
Here.
Miller.
Here.
Reingans.
Present.
Vanderwall.
Present.
Filler.
Yes.
Mueller.
Here.
Van Workum.
Here.
Roth. Schmaltz.
Here.
Thompson. Madam Chair, you have 16 members present. You do have a quorum.
Thank you. Representative Whitsett moves to approve the minutes from our meeting on March 9. Seeing no objection, the minutes are approved. Today we will be adopting a substitute and voting to report HB 4167, which we heard testimony on last week. I apologize for the lateness. You do have the sub before you in writing. We were incorporating a couple of changes on both sides, and Representative Morgan is going to come forward to give a brief overview of the changes. Welcome.
Thank you, Madam Chair and committee members. Good to be with you again. Based on the feedback from the last meeting and conversations over the last few weeks, we made some small changes to the bill, which is why you have a substitute today to accommodate those changes. They were thoughtful, really good changes. The primary change, I would say, is the reduction in the size of the committee, which we did in a way that doesn't compromise any of the groups being represented, but just kind of tightens it up a bit, which we know was a concern. A 26 member committee was a bit more unruly than 19 that we're looking at now. So nobody's removed in a way that would be troubling or anything like that, just tightening it up a little bit. We added some language around parents/guardians because we know some folks who are receiving care may not necessarily have parents who are caring for them. So in terms of who could be appointed as a parent or a guardian for one of the groupings. We changed a small bit of language saying that we want to make sure that diseases that impact those who are geographically disadvantaged are included, which is consistent with other bills with similar language and was a recommendation that came from this committee just to make sure that we're being inclusive in the work of the committee. Those are the primary changes. There's one additional one, which is just adding a line subject to appropriation to make sure that we're actually supporting this work if we're having the department help with the grants area or applying for grants. Those are the primary changes, but I'm happy to answer questions in any area that folks should have any questions in.
Are there any questions from committee members? Okay, I think we have a couple cards to read. Norm Hess from Michigan Association of Local Public Health supports the bill, and Amy Zagman of Michigan Council of Maternal and Child Health also supports the bill. All right, Representative Glanville moves to report House Bill 4167 with recommendations for Representative Miller moves to adopt the H3 substitute to HB 4167. Madam Clerk, will you please take the vote?
To adopt the H3 substitute to House Bill 4167. Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kofia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingans.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 19 yeas, 0 nays, 0 pass. The substitute is adopted.
Thank you. Representative Glanville moves to report HB 4167 with recommendation as substitute H3. Madam Clerk, will you please take the vote?
Chair Rogers.
Yes.
Representatives Whitsett.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Kofia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingans.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth.
Yes.
Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 19 yeas, 0 nays, 0 pass. House Bill 4167 is reported with recommendation as substitute H3.
Thank you very much. Moving on, we will now hear testimony on my bill, HB 4224, to repeal Medicaid work requirements for the Healthy Michigan Plan. We will be hearing from myself and Rachel Richards and Amber Belizaire from the Michigan League for Public Policy, as well as Adam Carlson from Michigan Hospital Association. Committee will stand at ease. Call the chair.
No, because they don't look like really. The committee will come to order. I apologize. Representative Rogers, please go ahead with your presentation when you're ready.
Thank you, committee members and Vice Chair Whitsett. I think we can all agree that this is a rather simple and straightforward piece of legislation. House Bill 4224 repeals the workforce engagement requirements implemented in the Healthy Michigan Plan in 2018. These provisions fundamentally undermine the intent and purpose of Medicaid, which is to provide health insurance and access to affordable health care to low-income families and improve their health and their health outcomes. Medicaid is not and was never intended to be a jobs program. There are so many better ways to encourage participation in the labor force, including the Earned Income Tax Credit, which at the time of this original legislation was at a historic low. In fact, removing health care access has the potential to increase barriers to employment as untreated and undiagnosed medical conditions make work difficult to maintain. I'd like to share an everyday example of someone who could be affected by these types of policies. Brad was working full-time hours, that is over 40, at 2 different jobs to provide for his family. He had a slip and fall on ice, hit his head on concrete, had a loss of consciousness resulting in a traumatic brain injury, and had extensive cognitive impairments affecting his ability to think, walk on uneven surfaces, have good judgment, drive a car, or work and this lasted many months. His life and that of his family's changed in the blink of an eye. You could argue that any one of us could have such a circumstance happen to us. He went from being happy and productive member of society to being depressed and not functioning well. After 3 months of extensive physical and speech therapy, he still could not function to the level he could before his accident, and so he lost his job. Since he could no longer afford the therapies, he ended his care. I am unsure what ultimately happened to Brad, but I hesitate to guess the circumstances and wonder where he is today. There are many stories like Brad's. This type of accident could easily happen, like I said earlier, to any one of us. Medicaid is a safety net, and medical care decisions, like when to discharge a patient, should be between healthcare providers and their patients, not the legislature. Imposing monthly paperwork requirements for families who are already stressed from a lack of resources and placing bureaucracy between patients and their doctors is counter to the entire purpose of Medicaid. In early 2020, a federal district court judge ruled in Young versus Azar that pursuant to similar cases from other states, which the U.S. Court of Appeals had found to be illegal, Michigan's work requirements could not be enforced. Let me say that again. Michigan's work requirements could not be enforced. In April of 2021, the U.S. Department of Health and Human Services withdrew the Michigan waiver that permitted us to enforce work requirements as a condition of eligibility. At the time, the head of the Federal Center for Medicare and Medicaid Services said that the waiver granted was no longer feasible as a result of the continuous coverage rule, and they had, quote, serious concerns about testing policies that create a risk of substantial loss of healthcare coverage, particularly as we were starting to experience the effects of the pandemic. Even if these work requirements had been fully implemented in Michigan, it is likely they would have been ineffective based on data from other states. For example, in Arkansas, their Medicaid work requirements showed no significant impact on increasing workforce participation, but did increase the rate of Arkansas's number of uninsured. If we truly are concerned about labor force participation, we would be better off getting everyone health care coverage and improving their medical well-being so that they are prepared to engage in the workforce rather than holding them hostage with the requirement of monthly paperwork. Regardless of the intention, at any time in 2018, these provisions are no longer relevant. Now that the federal government has withdrawn the waiver, the statutory language in sections 107A and 107B of the Social Welfare Act is outdated and, again, unenforceable. As the Michigan Department of Health and Human Services gears up to address the Medicaid redetermination crisis beginning April 1st, now is the time to remove any potential confusion, barrier, or question about Medicaid eligibility. We do not need to utilize MDHHS's limited resources preparing applications to the federal government for subsequent waivers which will ultimately be denied. Every hour spent preparing for a futile application is an hour that could be spent helping Michigan's Medicaid population determine their eligibility and assist them in maintaining coverage via the Healthy Michigan Plan or directing them to other benefits potentially on the exchange. In the end, my bill simply brings Michigan in line with the federal Medicaid program and removes irrelevant, unenforceable, and outdated language from the statute. Thank you, and if members have questions, I would be happy to answer them, as we do have 2 other experts willing to testify.
Thank you for your presentation. Do we have any questions from the committee? Representative Vanderwall.
Thank you, Madam Chair, and thank you, Rep, for bringing this forward. Just a couple questions, and I guess when we're talking about a bill that you said is unenforceable already, is there a real reason we need to bring that up and clear it off the books if it's unenforceable? And most, I guess probably the biggest thing is that that you and I have chatted, and I support work requirements. I just feel that if there's no work requirements, that we, disincentivize people from going out to work. And I guess I would love to hear your comments on both those questions. Thank you.
Thank you. One of my favorite quotes from Pope Francis is, "Who am I to judge?" And we do not know all the circumstances that face an individual, kind of like the story of Brad that I read. I will also say that we frequently eliminate old statutes all the time in this legislature. A couple of examples, I think there used to be a crime for trampling over blackberry bushes, and that is no longer on the books. There's been another defunct statute about, I think going back to something out of the Bible, wearing clothes of different cloths, So there's a lot of silly things that have transpired over the years, and just because something is no longer applicable, I don't think it's prudent to leave it lying on the books. And so if there isn't an ill consequence, I don't see what the harm is in removing it. In fact, I don't see any downside to this, as it's not going to cost the state anything. In fact, it may save us dollars. Thank you.
I would have to say, as a person with Lyme disease who, for everyone else, that's a mystery illness, I went from walking to not being able to walk, to falling, tearing up my front teeth in my mouth, not being able to walk straight, not being able to communicate effectively. So to be able to have to go and prove that I need my Medicare and Medicaid at that time would have been impossible. And I was taking care of myself. So I understand you, and thank you for the legislation. Representative Fitzgerald.
Thank you, Madam Vice Chair. You mentioned the redetermination that is pending here. What effect, if any, would the removal of this requirement have on eligibility, being an unenforceable requirement at this time? Can you speak to that?
Sure, thank you for the question. Again, we want to streamline whatever we can. Medicaid already has some different barriers and hurdles, and we're going to face additional ones since no one has had to submit paperwork for 3 years. So as we face the Medicaid cliff, as I call it, April 1st, I think whatever we can do to streamline the process would make it even easier. Also, I just would like to give another assurance to DHHS, who is up to their eyeballs trying to deal with this cliff. They just rolled out a package, which I greatly appreciate, of graphics and toolkits for us to be able to uplift this situation. So it's kind of something that's hanging out there over their heads. And so if we remove this barrier, they can concentrate and focus on that important redetermination work and not have to worry about, is the legislature going to ask us to put forward yet another waiver request? Thank you.
Representative Izakafia.
Thank you, Madam Chair. My question was answered earlier. Thank you.
Representative Farhart.
Thank you, Chairwoman, and thank you, Chair Rogers, for bringing this forward today. I heard you mention that as it pertains to repealing the work for Medicaid requirement, you said there will be no cost burden onto the department. Is that correct?
That is correct. In fact, it may save us dollars by not having staff apply for the waiver in the future. And so their efforts can be on other important things that are coming before them, like Medicaid redetermination.
And we could potentially see folks who would benefit from that Medicaid coverage, having healthier outcomes and staying out of like emergency rooms or, God forbid, really critical life instances.
Yes, the old adage, ounce of prevention is worth a pound of cure. And so when people have access to their doctors and therapists in a timely fashion, it does prevent ER visits.
Awesome. Thank you.
Thank you.
Any further questions? Representative Rankins.
Thanks, Madam Chair. Chair Rogers, did I hear you correctly say the major impact in Arkansas when they had work requirements was actually reducing the number of people with insurance and not actually increasing the number of people working?
That is correct.
Okay, thank you.
Seeing no further questions, the committee will stand at ease. Call the chair.
The committee will come to order. Next up, we have Rachel Richards and Amber Belizaire from Michigan League for Public Policy. Welcome.
Good morning, Chairperson Rogers and members of the House Health Policy Committee. I am Rachel Richards, Fiscal Policy and Government Relations Director for the Michigan League for Public Policy, and I have with me Amber Belizaire. She is a Senior Policy Analyst specializing in healthcare for our organization. We thank you for the opportunity to be able to testify this morning in support of House Bill 4224, sponsored by Chair Rogers, which cleans up our Medicaid program to remove unenforceable work requirements for our Healthy Michigan plan. For those of you who aren't familiar with the League, we are a nonpartisan research and advocacy organization that promotes economic opportunity for all and analyzes the impact of public policy on the lives of Michiganders who have been systemically left out of prosperity. The League is also the state's Kids Count organization, working as part of a national effort to measure the well-being of children, young adults, and families at the state and local levels, and to shape efforts that improve the lives of Michigan's children. We are pleased to support House Bill 4224, which would repeal the currently unenforceable and unimplemented work reporting requirements for those enrolled in Michigan's Medicaid expansion program, also known as the Healthy Michigan Plan. We were staunchly opposed to the legislation that created the work requirements and joined many other advocates and statewide organizations testifying in opposition at the time. As Chair Rogers noted, these are currently not implemented because a federal district court ruled that our work requirements, like those in other states, were unlawful, and the Biden administration formally withdrew Michigan's waiver in April of 2021. While we were fortunate to not experience most of the harmful effects of the legislation due to it not being implemented, we are concerned about keeping the currently unenforceable statute on the books for many of the same reasons we opposed the bill in the first place. And as you all have my written testimony, I'll just highlight a few data points and a few bits of research verbally. So primarily, Medicaid, and by extension, the Healthy Michigan Plan, is a healthcare plan, not a jobs program. The plan provides low-cost healthcare benefits to Michigan adults with incomes below 138% of the federal poverty level. So it's about $21,000 for a single person. And these are folks who generally don't qualify for Medicare or other Medicaid programs. Over 1 million Michiganders throughout every county in the state are enrolled in the Healthy Michigan Plan, and data from the Michigan Department of Health and Human Services show that nearly 78% of these beneficiaries have incomes below the poverty line. These are Michigan residents that run the risk of losing vital health care coverage should work requirements ever be implemented. To understand the impact of work requirements, we simply need to look at Arkansas, which did implement work requirements before a federal court vacated its policy. In Arkansas, over 18,000 beneficiaries, or about a quarter of those subject to their work requirements, lost coverage in the first 7 months. Things like complex and confusing rules, insufficient outreach, complex reporting systems, and lack of staff support all contributed to the loss of coverage. What's more is that we know residents working low-wage jobs often experience challenges and barriers to employment that would risk their loss of coverage, including unstable working hours, living in rural areas with inadequate job supply, and lack of employment supports like affordable and attainable and available childcare or reliable transportation or public transit systems. It's estimated that had Michigan implemented its work requirements, about 80,000 beneficiaries could have lost their coverage relatively quickly after implementation. This would have had a significant impact on their health and financial security, as it would have made it difficult for people to receive preventative and acute health care. It would have increased reliance on hospital emergency rooms and increased both uncompensated care and family medical debt. And this would have had a rippling effect across other areas of a family's life, as it would have made them to have to make decisions on whether to pay for food, housing, or health care, and making their position more precarious. Finally, data also shows that the work requirement is unnecessary, as Medicaid enrollees are generally already working or not working because they are a student or are due to a disability. In a survey conducted just after Medicaid was expanded, only about a third of Healthy Michigan Plan enrollees were out of work. The rest were working, unable to work for some other reason, retired, or were students or homemakers. The same survey also showed that having coverage made it easier for enrollees to look for work or made them more productive in their work. Simply put, improving healthcare access improves access to employment. The League strongly supports House Bill 4224, which protects this incredibly valuable safety net program in Michigan. We also look forward to working with the chair and other committee members on additional ways to improve our healthcare coverage and eliminate other barriers in healthcare. Thank you, and we are available for questions.
Thank you. Any questions? Wonderful. Next up, we have Adam Carlson from Michigan Hospital Association. Welcome.
Thank you, Madam Chair, members of the committee. Appreciate the opportunity to testify here in support of House Bill 4224. For decades, Michigan hospitals have made significant contributions, both financially and through the investment of time, effort, and personnel resources in helping connect men, women, and children throughout the state with healthcare coverage that is appropriate for their particular financial and social situation. The return on this investment has been remarkable, with more than 1 million Michiganders currently enrolled in the Healthy Michigan program. Despite the success of this program, though, pressures in the healthcare marketplace impact program costs in Michigan and throughout the nation. Many of these pressures, such as growing workforce expenses, insurer premiums for health care coverage, or the increasing cost of prescription drugs, are outside of hospitals' control and of the normal financial projections considered when the Healthy Michigan Plan won bipartisan approval in the state. The MHA was relieved when the U.S. District Court ruling invalidated work requirements in Michigan, which posed a coverage threat to tens of thousands of Healthy Michigan Plan recipients. The decision showed that attaching additional personal responsibility requirements unrelated to healthcare access fails to fulfill Medicaid's objective of providing healthcare coverage to Michigan's financially vulnerable population. Ensuring coverage and access for our lower income community members improves the health and wellness of our state while having a positive effect on securing and maintaining employment. As a healthcare leader in many of Michigan's communities, our hospitals will continue to work with patients to promote healthy behaviors that improve health outcomes. To codify this court ruling and ensure continued protection of Michigan's Healthy Michigan Plan, the MHA supports House Bill 4224 to strike the relevant sections of law from the Social Welfare Act. With that, happy to take any questions anyone has.
Thank you. Are there any additional questions? Minority Vice Chair Vanderwall.
Thank you, Madam Chair, and thank you for your testimony. I guess just a real quick question, if right now with no work requirements and Medicaid, how many people currently come into the hospital system that have no insurance at all?
So it's significantly reduced since the passage of the Healthy Michigan Plan. And the way we know that is not only through the data of the individuals, but also the reduction in uncompensated care that hospitals have had to bear since Healthy Michigan Plan went into effect.
So what would you estimate the average hospital writes off as free care, and do you believe that the work requirements would actually increase that?
Yeah, last year it was nearly $1 billion, according to our community benefits report that is produced by the MHA. But if more of those individuals who otherwise should be on Medicaid were uninsured, that number would certainly increase.
All right, thank you.
Representative Thompson.
Thank you, Madam Chair. Mr. Vanderwall actually asked my question, so I'm all set. Thank you.
Okay, thank you. We don't have any absent members. There being no there being no further business before the committee will stand adjourned.